Our vision is to protect and pretty much promote the health of all Iowans, okay? And we exercise various different state laws to help us do that. And we have 6 divisions and licensing boards that report to us. So all of the state licensing boards, one way or another, report to the Department of Public Health when it comes to health or delivery of any type of health system. This changes. This changes. And so, you know, what I'm saying to you right now could change tomorrow. In fact, some things are changing. But I will say this is pretty much how our divisions are set up. We have the department, we have health promotion, chronic disease prevention. You heard that before. Well, that's the same division I happen to work under. So that's kind of a common pattern these days. We have different type of divisions: acute disease, behavioral health, environmental health, tobacco use and prevention, blah, blah, blah. So same things you see in most states, just different names, different titles. We are segmented by department, agency. Under the agency, there is divisions, and under the divisions, there are bureaus. And under our bureaus are offices, okay? That's how we are stratified. Each state does it differently. So within my division, which is the health promotions, chronic disease prevention, we have these various different bureaus: from family health, chronic disease, multicultural health, health communities, nutrition, that's our WIC, nutrition and health promotions, and we have local public services. These are regional offices, and then we have oral health and health delivery systems, which is my bureau, and I am the bureau chief as well as dental director for this program. We are one of the programs that is called a hybrid. I am not just the state dentist. I oversee a large number of programs. Dentistry, oral health is just one center within my bureau. Okay, so that's one of the newer, we call ourselves ODES, the mighty and the strong. And so this is just a series of all the programs in ODES. I'll talk a little bit about them as we go through, but I just want to list them here. We have what's called our Dental Home Project, which is our iSmile program. That's one of our, we're very proud of that program. It's our statewide care coordination system that integrates oral health in our Title V, or our maternal child health delivery system. It's quite fantastic. It's also a Medicaid hybrid, but I'll talk about that in a moment. We have our school-based student programs, and we are embedded in our maternal child health program, which we have 24 agencies in our state, and we have an oral health component in each of those agencies. Most of them have WIC, all but 2. We have a very good relationship with WIC in our state. We have a dental screening requirement, which is part of our law. So therefore, our school systems basically provide dental screenings for every child entering school and entering high school. So that is a part of our statutory law. We have also the Health Provider Access Program. Okay, that's called the Iowa Workforce. This is our Iowa Workforce Data System. We collect data and we create policies that actually help our legislators decide how and what changes in our workforce need to be made. We have the Rural Hospital Flexibility Program. And we have one of the largest number of critical access hospitals in the country, of 82. That's pretty big. We have the Primary Care Office, which oversees our HPSA, our health profession shortage designations. We have loan repayment programs of all different types. We have one strictly for dental, and we have one that has both dental and has medical in different types of professions. We have a small hospital rural improvement grant program. We have a state office of rural health. And all of these basically report under me as the bureau chief. This is the part of the code in which I, as dental director, I might well say, I'm impregnated into the code so that my position is kind of like permanent. So this is one of the first things we did. As soon as the window of opportunity opened, we got ourselves put in law, okay? So therefore, the state now has an obligation to keep me employed, or keep somebody like me employed. And so, but you'll notice the language says over an oral health bureau. Well, there was an oral health bureau. It doesn't exist now because oral health has been absorbed into now what is ODES. Okay, so that's one of the things that did change. And this talks a little bit about what I do. These are basic definitions of the oversight, both management, operational, as well as policies, as well as vision. It's just pretty broad. A lot of different things. Unlike many states, I mean most states maybe don't at this point in time, we do not operate local programs. In other words, the state of Iowa does not employ local employees. What we give is we give contracts. Our contracts are pretty binding though, but we give contracts, we give RFPs, which are requests for proposals, we put out every 3 to 5 years, and we get bids. And those bids, based upon those organizations that are eligible, we will give them a contract. And under that contract, we specify what terms they have to meet. Those contracts give them the authority to hire, like, dental hygienists. Dental hygienists can be employed by these agencies that work through our maternal child health contract, where they can draw Medicaid dollars down. So in other words, these hygienists are not self-employed. They are actually contracted or employed through these programs, these 24 agencies, and these agencies can bill on their behalf. And that's because of the relationship we have with our Medicaid program. So that's kind of a unique situation. So we have to provide the oversight in those situations. One of the things, key thing about being a dental director is this is the basic fundamental definition, and this is what ASTDD pretty much promotes as their general idea for a state dental director, is the person is visible, the person is a leader, the person is capable of facilitating various stakeholders and bringing them together on a common ground issue. And they can direct state and federal resources toward enhancing those oral health activities. So we're like magnets. Our job is to bring outside resources from across the country into our state and to pocket that resource toward those organizations that carry out our desire for oral health for everyone. So that's part of our job, being that magnet. We also have to be visible, not just to our state constituents, but to the nation. Because the more visible you are to the nation, the more you draw the nation's interest. Then you get people like DentaQuest and other organizations that say, what's going on in that state? And if they're interested, sometimes they're willing to invest. And when they invest, we are enriched. And there we can do more things, just like what you're doing here. Right now, I have to say in my state, we're highly enriched at this point in time because I have a number of funding sources. And I just received the CDC grant, just to add to what I already had. We weren't hurting to start with. And now we're doing a lot better. And that's pretty good. I mean, I started in the state with about a budget of $250,000 in the state oral health program. Now we're probably close to $5 million. And my staffing has increased quite a bit, and it's still growing. I have right now 17 reports. And I'm probably adding another 2 to that in the near future. So in other words, we continue to grow. And they're not oral health. Above the oral health component right now, I have exactly 6 right now, and I got 2 more I'm adding. So it continues to grow. So that's one of the good things I can say. Our oral health center has a mission. It's not unlike the departments. It's protecting the health and wellness of every Iowan through the prevention and early detection of dental disease and through the promotion of optimal oral health. Now the reason we wanted this vision is for this reason. We're not there to provide dental services. We are not there to take the place of a dentist. We're not there to compete with the dental community. We're there to augment what is there. We help them to do what is. I'll tell you an example. Dental community told us one of the reasons they don't like Medicaid patients because they don't show. They don't keep their appointments. If we had a way to ensure they kept their appointments, we'd be a little bit more willing to see them. So we had to create a program for that. Okay, that's part of the answer. We weren't going to, well, just get out of the way, we'll put somebody in and let them do the work. No, we're going to help you do your work by helping those patients show up. So we created a care coordinator system where our Medicaid data goes directly to those coordinators in the field. They track every single child. And those children are assured they will make it to those appointments. And we give those dentists a number. You call this number. If that person doesn't show, we are the ones you tell. You tell us. We'll get that patient there. So then that takes the burden off the practice. And they know that that will happen. And some of our hygienists actually will take the x-rays remotely to get them to the dentist. We'll send them by electronics to the dental office so they can predetermine what treatment they need to do. These are the kind of things we do to assist our dentists so they can do the things they need to do. That's part of what we feel our vision is and our mission. And so our goal is to make sure in the future every Iowan is free of dental disease. That's a lofty goal. But can it be done? We believe with appropriate prevention and early intervention, it can be done. In fact, it has to be done. So that's really our goal. This is just a breakdown of some of our programs. We have over 30 schools in our basic school-based sealant program. That's about to triple. I mean, with the new funding sources we have now, we also are partnering with Delta Dental of Iowa. I serve on the Delta Dental Foundation in my state, and we're allocating another $800,000, and we have also, as I mentioned, got a $1.8 million 5-year CDC grant. We're taking those resources, leveraging it with what we have in Title V, and now we had 7 school-based programs that were about a quarter of our state. We're now going to be able to supply up to 50% of our states who have 40% or higher free or reduced lunches for children. So in other words, we're going to have almost all of our kids covered, so they'll have at least basic sealant programs. So that's going to be very good. So once again, that's the advantages of a program like what we have. Our iSmile program, as I mentioned, there's some websites here that you could look up, just kind of get an idea. It'll be hard to explain to you in any one setting what iSmile does. It does a lot of great things. But one thing I can say is when we started iSmile, our state we were doing pretty good back then. We were doing about 28% of our, it's called CMS 416. This is the number of kids that Medicaid tracks that are actually getting a dental visit. We were about maybe in the 28 percentile at that time. Now we're at 53. And this has been in a 5-year period, and we are still growing. So each year we add another 2 to 4 or 5 percentage points to that number because we have these hygienists and we have these local coalitions bedded in all of our small communities, and they're out there getting kids in. And now we're looking at an adult component to that as well. And that's going to be a part of our Iowa Health and Wellness Initiative, which is a part of our ACA model that we will be bringing on. We brought part of it online now, and the rest will be coming on in January. So the iSmile is our flagship. Just see, does it work, or am I lost something here? Doesn't matter. So the key thing here is, and this is nothing new to you, so I won't spend time here, it's really a matter of building collaborations, networks. It's everything you just heard earlier about building networks with every organization that has some skin in the game. And there are many that do. Many that you may not know. You're visiting your home nurses, for example. You're visiting nurse agencies, probably have a lot in the game here where they're seeing people without care. Your community action programs. There are many different programs that have a vested interest in what's going on, both in institutional, in the corrections facilities, and in the homes that you can partner with that can become a part of this if it's not already a part of what you're doing. And so that's part of what we do. We try to make sure those partnerships are there. And this is just our spread out of our state. Wow. It's a bit elongated, okay? The key thing is for you to know is this. There are 22 agencies right now that are contracting agencies. And those agencies are responsible for those color-coded grids of certain counties they oversee. Now, if you look at one agency, like number 13, there are about 9 counties under that grid. That's about the state of Rhode Island. You could fit into that area. That's a big spread. And so those agencies often have to have more resources. And then there are agencies like number 14, which you see on the far right end over here, Scott County. That's a Davenport, city of Davenport. They have a high population, so therefore they only cover one county. So it's based on geographic as well as population, how many kids that have to be seen. And we try to balance it for everyone, and we give them a certain amount of money. So it just gives you an idea that we are a statewide program. So we do many of the things that you heard earlier, open mouth surveys, we do risk assessments. That's one of the unique things I will say about iSmile. We were very lucky. It was a few years back. We had the fortunate, serendipitous fortune of being invited to a meeting that Robert Wood Johnson sponsored in Philadelphia. And we had a chance to have a tutor named Dr. James Kroll from California, who at the time was very much into risk assessment. And so he gave us a model at that time and said, why don't you include this in your program? You want to have these kids come in, they're going to be screened, why don't you do a risk assessment and prioritize, and therefore you don't overwhelm the dental offices. Wow, did that make good sense? So that's exactly what we did. And that was back in 2002, about 2004 we did that. And so here we are today. Risk assessment is a normal part of everything our hygienists do when they see a child in intake. So in other words, we get a basic idea of the needs and we get them to the dentist based upon priorities. We have Medicaid services that are extended in our state. We are the only state in the union that offers a separate chip breakout for dental. We're the only one. Our S-chip program. We have what's called the Hawkeye program. You can buy dental by itself. If you have an existing medical plan, you don't have to drop out of it. You can keep it and buy into this as well. So we're the only one. And so those are just some of the things we've done. We have a comprehensive dental service. And I'm going to tell you a quick benefit of being a state dental director. You get the ear of the Medicaid director. Okay? And it's very good if your Medicaid director is a lawyer who doesn't want to get sued. And when you can sit down with his Medicaid director and say, did you know? And you start talking about the connection between systemic disease and oral health and uncontrolled bacteria in the gum lines and how that contributes to so many other risk factors. When you can have that conversation and that person bites tone and he says, so you're telling me this is a medical concern? Yeah, it is. So we've been thinking it should be in its own box, dental, and medical's in this box. You're saying this box blends. Yes, that's exactly what we're saying. And so what he went ahead and he changed the Medicaid law. Now we have endodontics covered, including ortho and perio. Comprehensive perio is a Medicaid benefit in our state because it's a medical necessity. A whole different argument. So those are just a few of the accomplishments I think that I've been able to bring to the state, not to mention the law for stone screening and the iSmile program, but I think I've been able to bring a certain sensitivity. I'm like you in many ways, Shani, when you said, what about dental? I mean, that's the first thing we do everywhere we go until people begin to say, oh no. And so, but you know what? It took almost 10 years and now it's beginning to pay because I'm seeing dental showing up in all of our major health initiatives right now. So it's happening. So policy development, once again, this is examples that we do. Assurance examples, grant writing, oversight of our dental program. We're managers. We are also funders. We do all sorts of neat things, I think, that are very important for us. And we do program evaluations, which is very important to prove that our programs have an impact. And these are all part of, and this is what Harry's going to talk about as our president, and I've had the pleasure of serving with Harry as a director on ASCDD's board, and we have worked very hard to try to get language how we felt every health program should try to meet. This is what our goal, this is our golden standard, and everyone should be trying to strive for. And I'm always proud when I see a dental director get up and say, this is ASCDT's 7 categories of our competencies, and we try to meet every one of them. Bingo. That's exactly the message we want to see going around. So, this is ASCDD. I'm going to leave that to Harry because I think he can handle that very, very well. So I'm going to give you the sage wisdom of our great leader, Harry.
Well. Well done.
Thank you.
It's really a great honor to be here. Thank you so much for inviting me. I will start off by being a little bit negative and say this is really not fair because, first of all, I got up 4 o'clock this morning, Eastern time. That's why I'm so anxious to get up here because I'm afraid I'm going to start keeling over pretty soon. Maybe you can stick around. I'm also, between you and your weekend. That's not, it's bad enough between you and your lunch. And then I got to follow these 2 guys who are just amazing. And then I come here and you guys are amazing. I mean, I wish I was here this morning. Just the short time I've been here, I've learned so much. And there's so much going on here, and there's so much excitement. And Shani, what you've been doing is phenomenal. So Bonnie, I would actually disagree with you a little bit that we really, can you imagine this kind of room 10 years ago, 15 years ago? No way. No way. And this is going on in a lot of states. Not every state. We still have a lot of problems. I'm not up here to sugarcoat things, but we have made great strides. We really have. Some of the things, of course, that Bob has been talking about, Matt, of course, all the stuff that DentaQuest is doing, and at such a such a systems level now is unreal. We couldn't even think about this kind of stuff years ago. So this is just really, really exciting. I'm here. Maybe I have the easiest part today. I'm going to tell just a story. I think it's really Maryland as a case study. I always go by the dictum. Bob knows I always say this: if you've seen one state, you've seen one state. And it's true. I mean, if listening to the CCO concept, I mean, that's not, we're also a health exchange state, and that's a foreign concept to us. And I'm going to go back and talk about this when I get back. But there are some similarities between the history that Cheney drew out and with Oregon and Maryland. And so, in talking about Maryland, and I'm going to really hone in not so much on our program, but really the partnership between a coalition and an internal advisory committee and a state oral health program. And its success. And I hope it doesn't come off as bragging. I hope it's more aspirational, because if Maryland could do it, coming from where we came from, any state can do it. And you guys have all the, right here in this room, and I'm sure you're in your own network. So, just that's what I'm going to be talking about today. So let me start I'm going to start at the end, and then I'm going to work back toward the beginning, and then come back to where we got here. Again, talking about going back in time. I mean, if someone in 1990, when I first started, told me that these types of outcomes would happen in Maryland, I would think, what drug are you taking? Honestly, it's just amazing where we've come, and I'm going to tell you, it's because we have partnerships in Maryland. And now we coalesced around an event, which I'll talk about. You probably, you all know what it is. So that event helped coalesce everything, but it really got us to this point because people sort of rolled up their sleeves and decided to cast aside their own agendas, stop whining about the past and all the problems, and move forward with solutions. And that's exactly what we did, and that's how it started. And I'll talk about the internal advisory committee in the department and how it morphed into a statewide coalition. But you can see some of our recognition, and this is where we've come. Now, of course, a child receiving a dental service, one dental service in the past year, is not the greatest indicator of anything, but it's our trend. And you can see that at the end of the 90s, not even 20% of kids had a dental visit in the last year. We're at 66% in 2011, and I just got the report, and we continue to go up. So our outcomes are there, and we're far surpassing the national average. This one's the remarkable one. I know there's a couple of dentists in the room in the back, and I hope maybe more in the room. But our state dental association, our state hygiene association, again, and there's some historical issues and animosities and all that stuff. And again, they sort of cast it aside to try to get to the big picture once this singular event occurred. And the state dental association came up to the department, and our health officer really read them the riot act. He basically said that if, I'm aware what's going on in Minnesota, I'm aware what goes on in Alaska, I'm not going to go there, but I want you guys to step up to the plate. I want you to go to your membership and see if you can participate in this program. And in about, I guess, 3 years, 4 years, we've added almost 1,000 dentists into the Medicaid program. And it can happen. And that's about 38% of licensed dentists. We still are going to go for more, and that's really in our state oral health plan to continue this momentum. And again, it was people coming together to get something done. In terms of some outcomes, we just have our school children survey, and we've halved untreated tooth decay in the last decade. We've doubled the amount of sealants in the last decade that have been provided. And caries experience remains lower than the national average. And actually, it's probably high up there because we're doing a lot more looking now, basically, our reporting. So there's going to be more reported, basically. But the key thing is a lot of these kids are now getting into care. And the key thing is now we're doing a lot more stuff up front. And I'm not going to get into all that in terms of disease management, disease prevention, in terms of from the get-go with pregnant women through the lifespan prevention, and in terms of working in WIC programs, Head Start, you name it, and that's where we're working. And we're not, we're certainly not there by any stretch, but that's been our strategy, as well as expanding our access points in the state. So that's sort of where we are now. This is where we came from, and we had one good thing happen for us, and I know the Portland story, and I'm not going to rehash that. It's sad. It's a national. We all lost. Really, we all lost. But water fluoridation in Maryland actually was instituted when water fluoridation really came into being. Most of our large communities, for whatever reason, I think we had some very great leadership at that time. At the State Health Department, and most of our cities in Maryland basically became fluoridated, as early as Baltimore was 1952, and many of those communities became fluoridated. So we right now we have about 93% of the public covered by water fluoridation. So my focus really is not even, my focus obviously is to keep my eye on the anti-fluoridationists. They're always around and lurking. I won't go there. But our focus really is making sure now that the water people think is fluoridated is actually optimally fluoridated. We're replacing fluoridation equipment. We're training water operators. We're getting them to be our ambassadors for water fluoridation, which has been something that we've done with our CDC and HRSA grants. So that's the good stuff. But the bad stuff is that oral health was not even existent. I mean, in terms of at the departmental level, for many, many years. We actually had some periods where the program was somewhat vibrant, but when the first round of cuts would come in, what would be the program that would be cut? Oral health. I mean, and why? Because we just didn't do we had our own little silo, and we were working well within our silo, but we didn't integrate into other areas, and we didn't really make ourselves known. And so it was an easy cut, and there was nobody crying. It was like a tree falling in the forest, basically. And so eventually, by the 90s, where you saw the early data of 19% access, we have 24 health departments, 24 counties, and maybe half of them had any kind of clinical dental facility, any kind of dental program whatsoever. We didn't even have an Office of Oral Health. I mean, it actually lost funding. We had a part-time dental hygienist who was just sort of, keeping the door open essentially, but that was basically it. And so in the late 1990s, I think the American Dental Association rated us 50th in the country for access to care. And you know what? You look at that last bullet. We had no partnerships. We had no advocacy. We had no advisory boards. We had no coalition. We had nothing. We had nothing, basically. And so, but I like that kind of stuff. It's really challenging because, first of all, you got nothing to lose because you're at the bottom. So there's no place to go but up. And I like that kind of challenge. And so that's pretty much where we really started. And in time, we actually would have these little guerrilla groups that would get together and start plotting the plan, essentially. And those were the first informal coalitions, essentially, even though we didn't even know it at that point. I mean, we weren't even talking about oral health coalitions back then. And things started to happen, and we actually, by accident, found a legislative champion who promised us that she would shepherd some of our ideas into legislation, and some of them actually held and took hold. And so things started to happen, and we started to grow. Just a tiny, we call ourselves the little train that could, because we started to expand. And so we started to do some stuff, and a lot of efforts were made, but still at the end of the day, in February 2007, our Medicaid reimbursement still basically had not increased for any considerable amount. Hundreds of thousands of Medicaid kids still did not have access. Only a small percent of them received any kind of follow-up service, and very few dentists participated in the program. And then this happened. And this is the singular event. Now, we know that there was a child in Mississippi who died on a school bus from a dental infection. There are other stories. If you talk to pediatric dentists, there are many stories probably of kids who maybe it was diagnosed as something else, but it was really from a dental infection. Why this took hold was because it had occurred in Washington, in the Washington, D.C. suburb. A reporter by the name of Mary Otto for the Washington Post, wrote The Perfect Story. And she's still around. She works with us still. She had no prior understanding of oral health, but somehow sort of melded the science with the passion and the fact that this was so tragic that it did not have to happen. It was so preventable. This child, and he had, had not an easy family life. He was homeless from time to time, but it was a typical thing when you don't have a system that's looking, and the kid is, or whoever it is not complaining, it ain't going to get found, and it's not going to get found. We know how chronic oral, once a tooth becomes necrotic, it's just a silent infection. It just continues, it festers, and his festered and reached his brain, and he died, and it shouldn't have happened. And he lacked, and what I also always say, and this goes back to our days with going back to working with WIC programs and perinatal programs and Head Start programs, is you got to start there. This kid didn't only lack access to treatment, which was what was really all reported. He never had a chance in the first place because he didn't. If he was in a Head Start program, for instance, he might have had a chance. He might have had some access to some prevention and education. That maybe, he might have had a screening that might have detected this lesion that eventually killed him. It's so tragic. And so this event really changed the landscape in Maryland. It really did. And you have to have some luck. You have to have some luck. We had the right people in place. We had the right governor. We had the right health secretary who just come on board. He actually was really not in the governor's camp, and he expended political capital to go to the governor and say, we have to do something here. And it worked. He took a real gamble. And then he came to me and said, this better work. He does that a lot. He just threatens people. and that's one thing, too. I already all of a sudden had this instant access to the health secretary, and Bob kind of mentioned how important that is, to go to the Medicaid directors and what have you. But anyway, he said,